All right, well, good morning, everyone. I think it's time to get started. Welcome, everyone, to Pediatric Grand Rounds this morning. It is a pleasure for me to present Dr. Kayla Lopez. Sorry for that. Kayla is a native of Chicago. She did her undergrad at University of Illinois Medical School at Rush Medical College in Chicago, and then pediatric residency at University of Chicago, and obtained an MPH in Minority Health Policy at Harvard School of Public Health as a Health Management and Policy Commonwealth Fund Fellow. She then completed cardiology fellowship at Texas Children's Hospital and advanced imaging fellowship there too, and then joined the faculty at Texas Children's and Baylor College of Medicine in 2012. She also has had a co-appointment at Rice University in the Department of Sociology and serves as a co-investigator for the Texas Children's Policy and Advocacy Center. She has been extremely accomplished, having been recipient of a long list of awards, including most recently this year, the American Board of Pediatrics Paul V. Miles Fellowship Award, which recognized her for the outstanding work to overcome health inequities in pediatric congenital heart disease patients and help transition pediatric patients into adult care. She also has an NIH Early Career Award to use technology to assist in the transition process in order to reduce health disparities in patients with congenital heart disease. She has a very extensive research portfolio reflecting a very long-standing commitment to addressing health disparities in public health initiatives. And she has presented nationally and internationally, long list of presentations, being really recognized in the world for identifying, describing and intervening on health disparities from the fetus to the adult, as well as establishing a strong, a really pioneer cardiology transition program in the country that she directs. And she really, through her research, she incorporates cardiology, public health, and minority health policy in order to develop research initiatives that directly inform health policy and improve the healthcare of minorities and underserved populations. So she's going to be presenting to us, the title of her lecture is Use the Force, Leveraging Technology to Reduce Pediatric Health Inequities. Welcome, Dr. Lopez.
Thank you so much. I'm thrilled to be here this morning, or to virtually be here this morning. I'm gonna go ahead and share my screen. All right, can everyone see that? Okay. So the objectives of my talk today are to understand pediatric health inequities, especially during the transition period for chronic disease adolescents, to understand the evolution of healthcare technology and adolescent use, to describe the connection between technology and the adolescent brain, and then to identify technologies that may improve health inequities for chronic disease adolescents. I have no relevant financial disclosures. However, I do have a few other disclosures. We will not be discussing any of the following technology. We won't be talking about Bitcoin or GameStop or augmented reality or blockchain, genomics, 3D printing. So if you have any interest in any of those categories, I would suggest that you refer to the Consumer Electronics Show, which usually happens every January, to get a little more information on those. So first, talking a little bit about health inequities, especially during the chronic disease period in adolescence. If we're going to talk about health inequities, we first have to talk about health equity. So health equity means that all people, despite their race, ethnicity, and gender, age, religion, or geographic location, or sexual orientation, have the equal opportunity to lead healthy lives. So in 1999, Congress requested an Institute of Medicine study to assess the extent of disparities in the types and quality of health services received by U.S. racial and ethnic minorities and non-minorities, to explore some of the factors that potentially could contribute to inequities in care. And that resulted in this report here, which was a landmark report called Unequal Treatment that came out in 2002. And what this demonstrated was that racial and ethnic disparities in healthcare exist, that they are tied to worse outcomes, that there's many reasons for these outcomes, including health systems, providers, and patient contributions, as well as systemic inequities and racism, and that there was a greater need for understanding of these processes. So since then, there's been reports that come out yearly. It's been 17 years since the initial report. And there really hasn't been huge changes in subsequent reports. You can see here in 2012, the Healthcare Disparities Report noted that while overall quality was improving, access to care was getting worse and disparities were not improving. And in the 2019 report, that some disparities were getting smaller in this 17-year period, but many disparities were persisting. Some were even getting worse, and especially for poor and uninsured individuals in all priority areas. So for example, African Americans and Native Americans had received worse care than white Americans for about 40% of the quality metrics that they measured. And Latinos received worse care than whites for at least a third of the quality metrics that they covered. So given this data, what can we say then about some of the health inequities in kids, especially for those with chronic disease? So what we know is that between 1960 and 2005, and it's been 16 years since that evaluation occurred, so you can imagine it's even more now, the percent of children with chronic disease in the United States has almost quadrupled, such that at least a quarter of kids are affected by chronic conditions. And racial and ethnic minorities are 1.5 to 2 times more likely than whites to have major chronic diseases. And furthermore, these chronic diseases tend to be more common in those with a lower socioeconomic status. And so if you look at what this means as you get into adolescence from the childhood period, this means that there is a transition period that goes from mid-adolescence to the early 20s that is a crucial period in chronic disease care, because it's a period when a lot of patients are at risk for dropping out of care. And there are some pretty critical definitions to learn about this period, such as the transition and transfer of care. And we'll talk about that in just a moment. But what we know is that there is improved survival for these chronic disease adolescents because we've improved our medical care, our surgical care. And so now many more of them are surviving into the adult period. And many of them then require skills such as self-management, having independence, and having knowledge of their disease processes to be able to make it through this challenging period that usually goes from 18 to 22 years, although some people argue it goes anywhere from 16 to 26, depending on what definition you use for the transition period. So I want to emphasize that transition and transfer of care are not the same thing. The transition of care refers to a shift in the responsibility of healthcare management from the parents to the patient. And so this is a thoughtful and gradual process that should happen years before one is transferring from pediatric to adult care. And it requires a lot of training for adolescents in this period to become better adults with skills. And the transfer of care then is the movement of patients from one medical facility or provider to another. And this can be very challenging because you can imagine a lot of these people did not survive the childhood period previously. And so it can be really hard to find an adult provider that cares for your specific pediatric chronic disease. And it can be really, really hard to leave the doctor that you've known your whole life, both for the provider as well as for the parent and the patient. So for what it's worth, given the similarities in the transition process for adolescents in the chronic disease space, I'm going to be using congenital heart disease, which is my area, as kind of the example of the chronic disease that we'll be talking about for the next few minutes. So what do we know about chronic disease from adolescence and transition into adult care? What do we know about people that make it? How many people make it to adult care, et cetera? Well, this study that I'm going to be describing is a study from Canada that looked at patients that were ages 22, and they looked at them between ages 0 to 22, and they looked at them in various age groups to see when it was that they actually fell out of care. And I'm going to remind you that Canada is a country that has universal health care. And so in theory, most of the individuals there actually have access to insurance. Despite this, what you see is that beginning at their 6th birthday, there's drop-offs and there's attrition in patients that are following up with these chronic diseases, such that by the time someone hits their 18th birthday, all the way on the right-hand side there, the total cumulative attrition from when they were first diagnosed to their 18th birthday is around 61%. So 61% of people fall out of care by the time they hit their 18th birthday in a country where there's universal health care. So this means that there's a lot of lapses in care for chronic disease patients. And again, congenital heart disease is one of these. So the question is, why are there so many lapses in care? Well, in the United States, certainly there's a lot of reasons that kind of go beyond other countries where they have universal health care. But some of those reasons from this paper in the Journal of American College of Cardiology in 2013 looked at some of these barriers. And some of these barriers included, well, I thought I felt fine. I didn't think I needed follow-up. I lost my insurance. I thought I was actually fixed. I was worried about getting bad news. I didn't know I needed any more follow-up. My parents stopped taking me. And so we know that there's a lot of gaps that exist in this space that are somewhat prohibitive to people obtaining care, or people just kind of have other priorities, and that's just it's not their focus, especially if they feel well. And then that's very, very true for teenagers. So are there racial and ethnic disparities in this transition period as well? And the answer is yes, there are. This is a study from 2010 that was done through the National Center of Health Statistics that was looking at this exact question. And they found that 65% of those with special healthcare needs had a poor transition outcome because of not having a medical home or no usual source of care. They had delayed care for the previous 6 months. They lacked insurance or had a gap in insurance. And for at least a quarter of patients, 25% of patients said that they could not find a healthcare provider that specialized in their condition because, again, these patients did not used to survive into the adult space. Furthermore, there was a roughly 1.5 times higher odds of not achieving a transition outcome of getting to the adult space if you were Latino or African American. And so knowing this, there's a variety of other inequities that develop in this space for adolescents with chronic diseases that we need to think about when we're thinking about the care of these patients. So social development inequities happen in chronic disease patients. So anyone who's had a chronic disease since childhood, we know that their development that requires normal autonomy and independence that any teenager would achieve is more challenged if you have a chronic illness, because you will oftentimes have less academic and employment achievement, less vocational education, less permanent employment. These individuals are less likely to be married, and they more likely have a delayed independence. And so, whether or not this can be made up in the future, I think is still unclear. There's some neurological inequities that occur in chronic disease patients as well. So this is a study looking at the late consequences of pediatric chronic illness that demonstrated that healthcare providers were increasingly aware that consequences of treatment can adversely affect the brain and compromise cognitive abilities. And this is particularly true if you were an older child, if you were a male, and if you came from a lower socioeconomic status household or a single parent household. Probably one of the most important findings from the study is that there was a finding of impaired executive functioning. And executive functioning is a process in which you have to have a lot of neurologically based skills that involve mental control and self-regulation and the ability to make complex multi-step decisions. And that involves a lot of your frontal lobe, which we'll talk about more in a little bit. But suffice it to say that without normally functioning executive functioning, it's more challenging to be an adult. There are psychological inequities that occur in these chronic disease populations as they age as well. This systematic review from 2017 looked at 8 chronic illnesses, including cancer, asthma, congenital heart disease, diabetes, cystic fibrosis, epilepsy, and they found 34 studies that demonstrated that there was at least a 1.5 times higher odds of anxiety and 1.3 times higher odds of depression in adults that had these chronic diseases. And as a matter of fact, in January of 2021, we published a paper on mental health and congenital heart disease, and we found that even if you have a simple lesion in congenital heart disease, a simple cardiac lesion, or if you are between the ages of 4 to 9 years old, you have at least a 3.5 times higher risk of having depression and anxiety compared to the general population. So this is not something that just happens as people age. It actually starts happening much, much earlier and in much more simpler diseases, chronic diseases, than we previously, I think, thought was real. So when we're looking at who is taking care of these patients, as we discussed, sometimes we can have an issue finding doctors for these populations. This is a study done looking at the comfort of general internists and general pediatricians in providing care for young adults with chronic diseases of childhood. So they mailed them a survey to people who had direct patient care. And they said, okay, let's look and see who is comfortable taking care or being the PCP for young adults between the ages of 17 to 25 for a variety of different conditions. And they found that internists, much more than pediatricians, felt that they were insufficiently trained or had a limited ability to care for young adults with chronic illnesses. And that was statistically significant. Additionally, they found that while both internists and pediatricians were comfortable treating patients with more common diseases, as you can see there, hypertension and asthma, that internists were actually much more comfortable than pediatricians caring for these young adults with hypertension, with chronic pain, with diabetes, and with depression. However, if you look at what the comfort level was taking care of individuals with congenital heart disease or cystic fibrosis, you can see that internists were far less comfortable taking care of these patients than were pediatricians. Beyond this, let's look at some of the training of these adult providers for these chronic disease conditions. So this is the current adult congenital heart disease training guidelines from 2015 that look at what an adult cardiologist, a general adult cardiologist, needs to be able to know about adult congenital heart disease guidelines and taking care of adult congenital heart disease patients. And so this demonstrated that what an adult cardiologist actually needs to do is they need to not have ever seen an adult congenital heart disease patient. They can look at these patients and refer them and know to refer them to adult congenital heart disease specialists for follow-up, but they're not expected to ever see these patients. And as a matter of fact, their training is limited to a suggestion of 6 hours of lecture. So it's a suggestion, it's not even a requirement. So you can imagine if someone walks into an adult cardiologist clinic with a procedure, otherwise, in other words, a half of a heart, the adult cardiologist is likely not going to know how to care for that patient. Beyond this, if you look at the number of board certified physicians that are taking care of these patients, you can see there in the left-hand column, adult cardiologists, there's over 31,000 of them. There's about 3,300 pediatric cardiologists that are board certified in the United States, but there's a whopping 447 adult congenital heart disease specialists to date that are board certified in the United States to take care of over 1.5 million to 2 million adults with congenital heart disease. So what that means is if for every one adult congenital heart disease specialist, there's at least 4,500 patients that they are supposed to be caring for. And obviously that is a math equation that does not make sense, nor is it feasible. So this is the reason why transition skills are so important, because of all of these disparities, and having adolescents with chronic diseases understand the disease processes, understand what they're supposed to know, get training in the transition period to be able to be better adults, because there's so many issues on the adult side for taking care of these populations. So here's what we don't want. We don't want adolescents to end up like this.
Hello, how are you guys today? We're good, how are you? Busy day. All right, so what seems to be the problem here? Her knee's been bothering her. It's never fun. Which knee? Her right one. Okay, and how long has this been going on? What? 2 weeks. Okay, does it hurt when you run? Yeah, it does hurt her. Sweetie, how old are you? She's 20.
So that's what we do not want. We want teenagers to be able to advocate for themselves, to be able to have their own voice. And for that reason, and the obvious other disparities that we discussed, we started a transition team over at Texas Children's for congenital heart disease patients, where we have a transition nurse, a social worker, and a clinical psychologist. And we had to kind of overhaul the organizational culture to be able to do this, because previously this was thought to be the PCP's issue. If they're going to transition, it's a PCP problem. But in actuality, it is a multidisciplinary situation where everyone needs to kind of have all hands on deck to help these teenagers become the best adults that they can be. So we've used a variety of different tools, such as this congenital heart health activation tool that we created. You can see a red, yellow, and green, likened after the asthma action plan, where we say this is what you absolutely need to know for your basic management, and then kind of basic long-term care. And then we found out that their parents were like, well, this is so wonderful that you're teaching my kids, but what about me? And so we actually even created a parent transition conference where we have various adult congenital providers for parents to meet, so they're not scared of them, they're not intimidated. They understand that this is a graduation of sorts, that this transfer of care is to be celebrated, and that they can anticipate this transition period will result in a transfer of care so that it's not a stressful moment. So the important thing here is that while it's wonderful that we've been able to create this program, we have the support for this program, the majority of programs across the United States do not have a transition program, whether you be a congenital heart disease program, a diabetes program, a spina bifida program, cystic fibrosis, etc. And so transition programs they're definitely not a one size fits all situation. They're definitely not cookie cutter situations. You can't have like one transition program that fits all disease processes, and they are poorly reimbursed. And so because of all of this, it is requisite that we actually use technology to try to help these adolescents in this space for having improved transition and transfer to adult care, and to better understand how to manage the disease and to engage them in the care of their disease. So technology can be used to reduce these health inequities. When you consider that 50% of teenagers and young adults belong to the Generation Z cohort, the majority of these individuals are actually unsatisfied with their healthcare experience. And as a result, they oftentimes are moving to alternative and traditional care with like technology, which is gaining traction now, especially after the pandemic. And so who constitutes Generation Z? Well, Generation Z is known as individuals that are high school aged as of 2018. They were born around 1995 to 1997. They're also known as the I generation. They have only known technology. They're much more tech savvy than the previous generations. And this is actually even in comparison to millennials, which are known as Generation Y. So to really tap into the future of technology, we need to leverage these tech native individuals to build products to reduce health disparities in this space. And what I'll say is, coming quickly behind this generation, just so that you're aware, next up is Generation Alpha. It's almost like a hurricane naming situation that we have here. And Generation Alpha are individuals that were born in the early 2010s, and they're even more tech savvy than the Generation Z was before them. So all this to say, we need to understand how then this evolution of healthcare technology can help adolescents and with their technology use. And we're going to talk a little more about the evolution of that now. So Moore's Law, what is Moore's Law? Moore's Law is the number of transistors that are incorporated into a computer chip will approximately double every 24 months. And that's from Gordon Moore, the Intel co-founder in 1965. And you can see here that sure enough, he was right. This is on the y-axis. You can see the number of transistors on a circuit chip that were used in computers and phones. And on the x-axis, you can see the years of introduction and the gains in the number of transistors, i.e. the ability to increase memory or RAM and data, have doubled every 2 years, as he stated. So that explains why we went from this in 1956, where this entire apparatus was what was required for 5 megabytes of storage, and has allowed us to go from these room-sized computers to smaller laptop and desktop computers, and even to what we call small handheld devices. We call them phones, but they're really devices. Because if you can see here, what used to be a desktop computer that had 32 megabytes of RAM and 4 gigabytes of storage, in an iPhone 4 resulted in 512 megabytes of RAM and 32 gigabytes of storage. And so that's impressive for an iPhone 4. But if you consider where we are now, looking at an iPhone 12, and again, I'm not advocating for Apple products, but this is just for the sake of demonstration, you can see now that the capacity over here for these storage devices are upwards of 512 gigabytes, as well as a variety of different chips that are bionic chips, and they are lighter in weight, and they have better resolution for pictures. They have a variety of different colors. And so you can imagine where we're even going to go to in the future based on where we are now. So if we're looking at Generation Z at a glance, these people make up 23% of the US population. That's over 68 million Americans. They are the most diverse generation, with nearly 48% being racial and ethnic minorities. They are the most educated generation, with nearly 1 in 2 getting a college education. And if you look at what their preferences are in terms of getting care, healthcare, a lot of them actually say, 41% of them say, you know what, I would actually rather have a digital experience than have an in-person, face-to-face contact with my doctor, as a general statement. That's not necessarily true for chronic disease people, but that's true as a generation as a whole. So they're the first generation that's born after the advent of the internet and social media. They are true digital natives. They have grown up with smartphones and tablets. It's like a second language for them. Their average attention span is 8 seconds. And so they are uniquely positioned to actually change healthcare. So what is it that they wanted of healthcare? They want quality improvement. They are the least likely to have a primary care provider. They are the least likely to be satisfied with their current healthcare model. So they often will look for effective and convenient and efficient alternatives, oftentimes in the form of technology. They are more willing to consider alternative practices of wellness medicine like acupuncture, and they are much more likely to look for digital capabilities to be able to interact with their healthcare providers, including things like getting test results and prescriptions online. So if we're looking at their technology use, as of recent data from 2019, 95% of teens possess or have access to a smartphone. 92% of teens go online daily, with 45% who say they go online almost constantly. The average 8 to 12-year-old spends 5 hours a day of screen time, and that it was pre the COVID pandemic. So you can imagine that's increased. And the average 13 to 18-year-old use entertainment screen media for an average of 7.5 hours a day, again, pre-pandemic numbers. So is technology accessible to all adolescents is the next question. It turns out that smartphone ownership is generally universal among teens, despite your sex, your race and ethnicity, and your socioeconomic status, such that 95% of all teens have access to a smartphone. As a matter of fact, if you look at how teenagers are using phones, 43% of African-American teens report going online almost constantly, as do 54% of Latino teens, and that's higher than the national average. 93% of adolescents come from households with an income of less than $30,000 a year. 93% of those have access to a smartphone. And 80% of teens living in rural settings have access to a smartphone. So as you can see, a lot of the disparities in the access to the actual smartphone has dissipated. Now, that's not true for data plans or broadband. That's still an issue. But in general, at least having the general access to these phones is somewhat more ubiquitous now. What we all do know is that COVID-19 was a major game changer, though. This had a major impact on lifestyle and behavior for kids and adolescents. We know that the COVID-19 accelerated the use of telemedicine. We know that it increased patient portal and online medical access. And we know that this also changed physical activity for students, such that at least in China, you can see that 21% of adolescents were previously active, and that jumped to were previously inactive, and that jumped to 65% that were inactive during the pandemic. And screen time was also heavily increased, as not only for learning, but also for leisure time. So what does that mean for an adolescent's brain now that we're using all of this technology and teenagers are using so much online technology? So first, we need to understand a teenager's brain. So the first thing is that the limbic system is fully active and working in teenagers. So this is a system of complex nerves and networks in the brain that is where instinct and mood lives. It controls basic emotions like fear, pleasure, and anger, as well as drives like risks, rewards, and impulsivity. So fully active in teens. What's not fully active is, as we talked about before, the frontal lobe. So this is the last part of the brain to develop, and it is the area that's responsible for impulse control and judgment, empathy, social behavior. And for those of you that have teenage children, this may make sense to you now as to why they behave the way that they do. And it also is important for executive functions. Adolescent brains, we know, are only about 80% of the way to maturity. And it takes until their mid-20s and even later, if you were a patient with a chronic disease that had a childhood chronic disease, to become fully mature. And this is a lot of the reason why transition programs that are tailored to education for patients with chronic diseases are necessary to help increase their likelihood of a successful transfer of care. And what's interesting is that in different countries, they're actually expanding the definition of adolescence. So in Australia, they now consider the adolescent period to go all the way to 26 years of age because of the maturation of the brain. We know that social media affects the teenage brain. There's been studies that have done looking at what happens when teenagers are looking at these various apps, including something like Instagram. So this study from UCLA looked at an fMRI scanner with teenagers in there looking at their Instagram. And what they found is that certain areas of the brain lit up whenever they had things that people liked, so that the brain's reward center was becoming especially active. And that was kind of a feedback loop for someone to get somewhat addicted to social media. So we know that time spent on social media can actually change the brain and cause it to grow. And I think a lot more of that information is going to be coming out from data from the pandemic. So how do we give chronic disease adolescents health information, knowing what we know about their technology use and knowing what we know about their brain? there's certainly a complex relationship. And so we need to do a lot of information gathering to figure out how these teenagers want to actually receive information, and especially for those with chronic disease. So this is a study that we did looking at 20 adults and 20 adolescents with moderate to severe congenital heart disease. And we found that while the majority of them, as you can see, 85% still want to receive information through their doctor, they were actually amenable to receiving information through websites and apps and through the use of checklists, so that they actually knew what they had to get done to be more successful adults with congenital heart disease. What they did not like, they didn't want to be watching presentations online or getting emails, and they certainly didn't want to get brochures. And so we know that getting to a teenager is definitely not through our traditional methods that we used to use, but through technology. So what does this mean when you're thinking about how to create technology then for adolescents? This means that we know that there's cognitive deficits that these chronic disease adolescents have. So we have to do and make apps that target executive functions. We know that social platforms are critically important to this group of individuals because of how they connect with each other. And so creating apps with connectivity with peers is going to be very important. Having a reward and feedback mechanism that helps for patient engagement is going to be critically important when you're thinking about how to develop your technology. Mobile delivery of information is really important as well, because it is obviously the most used platform for teenagers. And then finally, design. There was a shocking study that came out that demonstrated that if you were a teenager, if you thought that an app was ugly, even if it was useful, you would actually delete it from your phone because it looked ugly. So design is also critically important for these individuals as they use technology. All right, so now let's talk about some technologies that potentially can improve health inequities for chronic disease adolescents. And I'm going to go over a few coming from larger healthcare systems like the electronic medical record and things like machine learning, as well as some on the individual level, including telemedicine, mHealth, social media, gamification, and crowdsourcing. And obviously, from the individual level, these things kind of feed back to the larger healthcare system, and it's part of the reason why they're pretty important. First, let's talk about EHRs or EMRs or electronic medical records. So in March of 2012, the US government announced the Big Data Research and Development Initiative. And this is where they started really accelerating administrative claim records, clinical registries, electronic health records, biometric data, and biomarker data to get at more understanding of larger population-based issues. And, so one example in the pediatric space is people using PHIS, or the Pediatric Health Information Systems database. And the strength of using big data in terms of understanding chronic disease inequities and who it impacts and the most is that you can find these associations and correlations and identify patterns and mix complex data. And that's really great and important, but we need to understand that EMR use and big data can actually further drive health inequities. So when you're considering using big data, you have to consider certain aspects to be able to minimize perpetuating health disparities in this space. So understanding that, from this paper from 2017, looking at opportunities to address health disparities, that if you're going to use big data, you have to actually also use demographic information. But beyond that, you have to understand social determinants of health, and those should be a part of the medical record, because we know that race is a social construct and that your zip code matters a lot more than your genetic code. And so understanding the social determinants in the area in which you live and grow and work are much more important than your actual race and ethnicity. Enhancing public health surveillance by linking a lot of your records to geographic variables and social determinants of health is going to be critically important to understanding how to address health disparities using big data, and understanding the etiology of health disparities, such as where does it come from longstanding systemic inequities, from implicit bias, from systems of racism, to help understand minority health and to guide interventions is critically important as we use big data. And so in my own experience, we have used big data to look at some of these health inequities. I've worked with some sociologists over at Rice University to look at some of these, and we look at neighborhood level impacts of chronic disease. So we look at walkability of the neighborhood, environmental toxins in the neighborhood, to look at diseases such as chronic childhood asthma to determine how much of the environment plays a role in children developing these diseases, and also in who is getting these diseases and where do they live. There's also a study that we did looking at adults with congenital heart disease and their access to care using GIS, or Geographic Information Systems mapping, with the help of some of the epidemiologists that we work with. And this one, as you can see there, that these are centers in green that are adult congenital heart disease centers. And the various blue colors and gray colors are the driving distance to those centers that we made using information that was available online for adult congenital heart disease patients from the Adult Congenital Heart Disease Association website. And we determined who it was that lived the furthest from care from these specialized centers that are specifically equipped to take care of these chronic disease patients. And we found that the people who lived the furthest were those that the furthest drive time were those that were less insured, less educated, those that had the highest levels of unemployment, as well as Latino populations. And so we've been able to look at a variety of these different things using big data. We also used big data in terms of these administrative databases. So this is the National Inpatient Sample database, which looks at a variety of different hospitalizations and hospitalized adults. And we looked at it to see what were the insurance rates for congenital heart disease patients in the transition period under the Affordable Care Act, to see if there were resulting inequities despite the Affordable Care Act in insurance coverage for these patients. And what we found is that over there in the x-axis, you can see 2007 and 2009 is before the Affordable Care Act, and 2014 and 2016 is the full Affordable Care Act, that despite the Affordable Care Act, you still had a higher percentage of uninsured adults that were hospitalized that were Latino in red, the highest being in the transition period, as well as African Americans in blue compared to non-Hispanic whites in the black colors there. We also use big data using the National Center for Health Statistics and the Wonder database with the help of other epidemiologists to look at mortality from congenital heart disease across the lifespan. And we found that disparities continue to persist across the lifespan. If you were male, if you were African American, you had higher mortality all the way up to the age of 40 for congenital heart disease patients. And that if you were a Latino, that your disparities also persisted in the infant period, because the rates of infant mortality for Latinos with congenital heart disease didn't change over the study period, whereas it went down for non-Hispanic whites. And so we do use a lot of big data to help us understand better some of these health inequities. But again, using race and ethnicity alone is insufficient to evaluate what is going on here. And you have to consider some of these other processes, like I said, like social determinants of health and systemic inequities. All right, so what about machine learning? What is machine learning? It is a part of artificial intelligence, which is a branch of computer science that attempts to emulate human intelligence. And machine learning is one of the most rapidly growing fields within artificial intelligence. And it's a domain in which machines are emulated to gain intelligence without explicit programming. So it uses mathematical algorithms to improve learning through experience. And it is being used to advance diagnostic, management, and prognosis in pediatric specialties through ongoing data gathering. And so in 2021, there was a review that was done looking at these different processes. You can see on the y-axis and the right, diagnosis, management, and prognosis. And then you see the different specializations on the y-axis and the left, from radiology all the way to cardiology. And you can see that the number of papers using machine learning is demonstrated by the size of the circles, with the largest circles demonstrating at least 5 papers using machine learning in these areas. So we know that because there's constant monitoring in ICUs, as well as volumes of imaging data in radiology, neurology, and cardiology, that this makes machine learning more feasible in these fields. And this can yield less user error than what humans alone can produce. And it can also help in a variety of different ways. Most interestingly, it turns out that psychiatry is one of the highest fields that uses machine learning, because they have difficult to diagnose conditions such as autism and ADHD that are time and resource intensive. And so by using machine learning and these conventional diagnostic tools can be funneled to include minimum features required for accurate diagnosis for these conditions. So this is something that's coming and it's being used more and more in a variety of different fields as we learn how to harness kind of real-time data and bigger volumes of data. What about telemedicine in teenagers? Well, what we know, and this is going to be all information that's coming from Common Sense Media and the research that they did in over 1,500 adolescents in a national survey looking at how adolescents interacted with social media and with telemedicine in 2020 during the pandemic. What we know is that online health resource use over between 2018 to 2020 changed pretty significantly. So if you look at who was connecting to healthcare providers in 2020 versus 2018, you can see that that number more than doubled. And that was even as people were going back to in-person visits, that's persisted. If you look at across ages and sex, male and female, you can see that even 14 to 17-year-olds were using searching for online information almost as much as 18 to 22-year-olds, and sometimes even more when they use their mobile apps to search for healthcare advice. And they were using it in similar ways to these older adolescents. For males and females, you can see that females had more use of online health resources. But when you look across races and ethnicities, you'll see that the differences in who was using online health resources and how they were interacting with their providers is actually not dissimilar. And it was not statistically significant differences between these groups. So that's important because it means that we are able to actually harness this technology to potentially get at populations that previously had a hard time accessing care, like those in rural populations or those that have a harder time getting to these larger tertiary care centers. You can see here that this is who connected to healthcare providers via various platforms, including video appointments, text messaging, online messaging, et cetera. And that between 2018 to 2020, that number went from 20% to 47%. If you look at mHealth technologies, the National Institutes of Health refers to mHealth as any wireless device carried by or on a person that accepts or transmits health data. So this includes watches, phones, wearable devices, etc. This is another way that we are getting a lot more information about chronic disease adolescents. So you can see here, over time, different technologies have increased in their use. You know, it used to be wearable GPS. Now smartwatches are much, much more highly used. Activity trackers, I think, are probably less used by teenagers, but smartwatches certainly are much more used, as are phones. And so understanding that wearable technology has increased allows us to help chronic disease adolescents getting information in a way that they understand and in a way that they can get quick access to some of this data, and that we can get quick access to some of this data to help them. Especially, you know, this is especially true if you're trying to help someone with weight loss or someone who has diabetes, because getting information in real time can be very helpful. If we look at text messaging and mobile phone applications as interventions, the verdict is so-so in terms of whether or not these interventions can help chronic disease patients. This is a systematic review that was done in 2017 that looked at over 15 articles. And then what they showed is that while over half of these studies showed a significant improvement in treatment adherence for patients that used text messaging and mobile apps for their chronic disease, the quality of the data in this review was in the low to moderate quality. So it wasn't really robust data. There's been more studies that have looked at mobile health interventions for improving health outcomes in youth in general. And what these other papers found was that there is a really important moderator for mHealth interventions, and that is the caregiver. That's their parents and their doctors. So how much their parents and their doctors actually engaged with them on these mobile applications in terms of encouraging the use and actually having them use so that they knew kind of what the teenager was exposed to and what the app was meant to do actually significantly enhanced the teenager's use of that device. And so that has to be kind of a critical piece of understanding how teenagers might do with mobile app interventions. One other thing is that teenagers with chronic diseases, they want to be more communicative with their providers, but they don't want to feel judged. And so this is a study that looked at how teenagers feel when they're doing inpatient versus digital communication with their providers. And many of them said, actually, I prefer digital communication because I don't feel judged and they can't see me. So this might be a better way for me to kind of be honest about how I feel. And so because of this, it actually is critical that we employ teenagers in the development of apps and in how we're developing these technologies because without them, they are the true digital natives. We are not. So without them, the ability to make something for them and create something that they will use and enjoy will be very, very challenging. So incorporating them on your team is of critical importance. And we took that into account when we started developing our own mobile health app with a thanks to an NIH grant that I have, an early career grant, to build a mobile application for chronic disease patients with congenital heart disease in the adolescent period to help them with their transition. And so we actually employed expert panels of teenagers to help us understand what they wanted, how they wanted to receive data, what should be on the app, and, of course, within reason. Some of them asked for really challenging and expensive things, but beyond that, here's what they told us. They said, I want a tailored application. I don't want something that lumps me and says that all CHDs kind of are the same. I want to say, this is my congenital heart disease. I want a checklist to know what I need to do to be a successful adult. I want a way to monitor my progress. I want a portable medical summary so that if I land myself in the ER, I don't have to explain what I have. I can just show someone my phone. I want education specific to my disease. I want to focus on what to do if I have an emergency. I do not want to take quizzes or full quizzes. I want mentorship. I want ACHD mentors, so people who've kind of been there, done that, to talk to, and some social media platform where I can talk to other adolescents or at least read their experiences, like through blogs and things. So we are now in the usability phase of our app, where we're now developing, having images for individuals, having various platforms where they can learn, and hopefully we'll have a prototype of this for pilot testing over the summer. So important, social media. So we touched on social media a little bit in the past, but it really is critically important to understand, social media as it has been somewhat vilified in medical circles. And I think it really matters how we talk about social media in terms of who is using it, why it's being used, and how it can actually help teenagers with chronic diseases. So first, you need to understand who is using what platform. So we know that Instagram, half of Instagram users are Latino and African American compared to the smaller shares of Caucasian Americans who use Instagram. And we know that the app WhatsApp, Hispanic Americans are using that much, much more than African Americans or white Americans. And so if you're going to be developing something, understanding that those two platforms are really heavily used amongst minority populations. Beyond that, let's look at who is using other social medias. So the one caveat to this I'll say is that the one social media that is not on here is YouTube. And that is currently the most used social media platform in adolescents and young adults, going from ages 14 to 26. That is the highest used social media. So what you can see here between the fall of 2020 to the spring of 2016 is that while you start off using a lot more Facebook and Instagram, that number switches by the time you get to 2016. So teenagers can be somewhat fickle and change their media use pretty quickly. And then if you go all the way to 2020, you can see by the time you hit 2020, TikTok didn't even exist a couple of years ago. And now TikTok and Snapchat are some of the highest used social media platforms for teenagers, as is Instagram, as we discussed. Whereas if you look at Facebook, it's a whopping 2%. So clearly they're not using that one anymore. So understanding what they use, why they use it, and really kind of likening some of your own data development after these can be somewhat helpful. Well, what have we learned about social media during the COVID-19 pandemic? A year into this pandemic, we learned a lot about mental health and coping and what social media does and does not do for some of these teenagers. So what we learned there on the x-axis is that social media can actually have positive effects on your mental health if you're in isolation. And a lot of that is actually true for chronic disease patients. So if you look at who's anxious and depressed and lonely, in the lighter green colors, you can see that they felt that social media helped them more than it hurt them in these various chronic disease populations in terms of the effect of their mental health. They felt less anxious, they felt less depressed, and they felt less lonely. And that's also true for when you look compared to 2018 to 2020 in terms of how does social media make you feel? Does it make you feel more depressed and stressed and anxious? In 2020, people said, actually, it made me feel better than it made me feel worse. And that's a big change. This is also true for how they use social media. They felt that they could express themselves, that they got inspiration, that they felt less alone and that they were getting advice compared to 2018. And so if we're looking at social media then about who is having untoward effect, you have to understand who else is having, where else are the impacts happening on social media, especially as it was during COVID-19. We know that Black youth were disproportionately affected by COVID-19, and that the majority of Black youth actually encountered racist content online or on social media, with 37% reporting symptoms of severe depression. But we know that 90% of Black youth have used digital tools for health, and 4 in 10 have used telehealth services. For Latinos, we know that they were also disproportionately impacted by COVID-19, and that 67% of them encounter racist content online and on social media, and 37% of them reported symptoms of moderate to severe depression, but that 93% of them use digital tools for health purposes, and over 40% use telehealth services. What about the other vulnerable group here, the LGBTQ group? The majority of LGBTQ group encounter, over 75% encounter homophobic content online and social media, and 65% report symptoms of moderate to severe depression. But 98% of them use digital tools to look up health things, and over half of them have used telehealth services. So there is a real opportunity here for helping these individuals through the use of social media and other online health platforms. The last thing I'd like to cover on social media is that hate speech is a real thing on social media. So understanding who is using it, when they're using it, how they're using it, and what they're seeing is critically important. So racist, sexist, and homophobic commentary has increased in 2020. And exposure to that has increased also in 2020 in terms of body shaming, racism, sexism, and homophobia. And so a lot of people are encountering this often as opposed to just sometimes. Briefly, a word on gamification. Gamification actually helps engage teenagers in social media use. So the use of making things fun, making things seem like a game even though you're learning. So using avatars and badges and things in the form of checklists and certificates and activity completion actually helps teenagers with chronic disease. So there's studies that have shown that 71% of teenagers would use a lot of these apps more if there was gamification included, especially for chronic disease management for these adolescents. And then there was another study that looked at gamification in 2016 for health behavior apps, and they found that only 4% of greater than 1,600 health apps included gamification. And if we really want to reach teenagers, this is something that we need to change to engage them. Finally, crowdsourcing. So you've heard of crowdsourcing. Everyone has heard of GoFundMe. Everyone's heard of Kickstarter. And so crowdsourcing really is the crowd getting behind a common goal to solve problems and increase the efficiency and speed of productivity through people, purpose, participation, platform, and productivity. Those are the 5 principles. And so there has been evidence that shows that this can actually help chronic disease use. So this was a study that was done in Philadelphia, looking at where they could find AEDs for patients that might have these issues. And they looked to see where these AEDs were placed in the city. And so the crowd kind of participated in this game to see where these AEDs were concentrated. And they found that the majority of them were concentrated in areas in Philadelphia that were higher SES areas. And so this helped identify where there was a deficiency in AEDs to be able to get them to lower resource areas. So this can be used as well. So I think we need to, in summary, embrace technology if we want to work with chronic disease adolescents, because it's not going away anytime soon, especially as Generation Alpha comes up. And that we need to really work with teenagers, because we know that this is how they live and they interact with the world. And there's a variety of different ways that we can do that to try to help them reduce these health inequities. And I'm happy to take any questions.
Thanks so much, Kayla. That was amazing presentation. I'm so much looking forward to this app that you're working on. It's such a big need for us. We face so many challenges in congenital heart disease in the transition process. Not only obviously the lack of ACHD physicians, but also the parents often. So I really enjoyed when you brought that up of the parent transition conference. I wonder, how other programs can embrace that you did, because we often find that when we bring the concept to the parents about transition, say, no, they're so afraid of the change. They just want to stick to the physician they've known all their life. And anyway, so I'm just wondering how we can take some of all the amazing work you're doing and apply it in some of the other programs that are needed in some of the same needs, especially the app that you're working on. That's super exciting.
I am excited about that. Hopefully, of course, COVID slowed everything down. We were supposed to do testing back in 2020, but that's okay. Here we are now, working on it now.
Yeah. So do you think, for ACHD physicians, is there something the country needs to do to create more it's 2 years training. So, and then after finishing cardiology fellow, you have to do 2 more years. And if you're coming from internal medicine, that's the same thing. And it's just, it's tough, right? And we just have such a need.
I mean, I think there has to be incentivization for individuals to enter that field. I mean, whether that comes in the form of policies that say you have debt forgiveness if you go into this field because it's such a high need.
Yeah.
And I think we have to come up with creative policy solutions and payment structures to have pediatric cardiologists and ACHD physicians partner with adult cardiologists, because the math is just not there. I mean, last year there were 5 graduates for adult congenital heart disease, and the year prior to that there were 7. So the math is not, it's not going to add up over time. And so I think we have to come up with creative policy solutions and reimbursement strategies to try to assist in the care of these patients that have such a need for specialized care.
Yeah. Loretta Mateo has a question. Tremendous presentation. Do you think that the app you're working on for teens and adults with congenital heart disease will help with the challenge of distance to providers that you showed on your slide of U.S. physicians qualified to treat those with congenital heart disease?
Well, I think you have to start somewhere. And I think if you're going to be starting with teenagers, technology is kind of the way to go. And so if you don't have a transition program in your facility, in order for you to have the skills that require you to navigate in a complex medical system, if you have a chronic disease, especially because a lot of people don't know how to take care of you, it's critically important that you understand who are the providers that need to take care of you, that you understand what is an emergency for you, that you understand what are skills that you need to be able to voice when you disagree with something, to be able to interact with the provider and ask questions and maybe question some of the care that you're getting. So a lot of these are skills that are learned. These are not skills that just come automatically for teenagers. And so developing those skills through the form of an app, I think could potentially help with the dearth of physicians that we have to take care of these adult populations, in that people are going to be acquiring skills that will ultimately help them get the best health care that they need. It may not help them in terms of getting the absolute care, but at least they know what constitutes an emergency, what disease process they have, why they have a scar on their chest, etc. I can't tell you the number of times that we've had adult congenital heart disease patients come in, they have a huge scar on their chest, and you say, what happened to you? And they say, I don't know.
Yeah.
Because they're what we call their historian, or the person who was taking care of them, like their parents, died, and their history died with that parent.
Yeah.
And so it's a real challenge.
Absolutely. Yeah. Wonderful. So I think we're going to wrap this up because we're going to move to the meet and greet, and then we can have more questions and comments. And we wish we could do this in person, of course, Kayla, but there is a different link to the meet and greet. So we'll move to that and welcome anybody who can join us and chat a little bit more about this fascinating subject that's really a big challenge that we're all dealing with our patients. Thank you so much, Keila. We'll
Okay,
join in a second in a different link.